You have been told the warning signs of heart disease your whole life: chest pain, left arm pain, shortness of breath during exertion, and you have believed it because that is what everyone says. That is what gets repeated at every doctor's visit, on every health website, in every commercial for heart medication. But here is what nobody tells you. Those are the signs of a heart attack that is already happening. I am talking about something entirely different. I am talking about the signs that show up weeks, months, even years before a crisis. The clues that your body is quietly sending you right now. And most people miss every single one of them, not because they are not paying attention, but because nobody ever taught them where to look. Around 47% of American adults over the age of 40 have some form of hidden or undiagnosed cardiovascular disease. 47%. That is not a small number. That is nearly half the population walking around with a heart condition they know nothing about. And the reason so many cases go undetected is not that the signs are invisible. It is that the signs show up in places nobody thinks to check. Your pillow, your fingernails, the skin beneath your eyes, the way your ankles feel at the end of the day. These are not random details. These are the exact clues I look for when evaluating a patient I am worried about. Today, I am going to walk you through 7 of these hidden signs, and I want you to do something while you watch. I want you to actually perform these checks on yourself, not later, right now as I describe each one. Because the earlier these patterns are caught, the more options there are. And I can tell you from experience, the people who act early are the ones who keep their independence, their mobility, and their quality of life well into their 70s and 80s. The people who wait are the ones I see in the emergency department, wishing someone had told them sooner. Before anything else, I need to say this clearly. Everything I share today is based on published research and clinical observation. This video is for education only. It does not replace a proper medical evaluation. If you recognize any of these signs in yourself, bring them to your doctor. Write them down and bring that list. A good physician will take it seriously. With that said, let me show you what to look for. Now, before going any further, I have one question for you. What is the health concern that keeps you up at night? Is it your heart, your blood pressure, your energy levels? Whatever it is, type it in the comments right now. I read every single one, and knowing what you are dealing with helps me make better videos for you. Sign number 1, how many pillows do you sleep with? Stay with me, because I know that sounds like the strangest possible opening to a video about heart disease. But this question has told me more about hidden heart failure than almost any other question I ask in a clinical setting. And here is why. When the heart begins to struggle, it loses its ability to pump blood forward efficiently. Blood backs up. Picture a traffic jam on a highway. Cars are still moving, but the congestion is building behind a bottleneck. In the heart, that congestion builds upstream. The backed up pressure pushes fluid out of the blood vessels and into the lung tissue. This condition is called pulmonary edema, and it makes breathing harder, especially when you lie flat. Here is the critical part. When you are upright or sitting, gravity helps keep that fluid pooled lower in the lungs, toward the base. You can compensate. You might feel slightly winded walking upstairs, but sitting on the couch, you feel fine. But the moment you lie completely flat, that fluid redistributes throughout both lungs. The breathing space shrinks, and your body, without you even consciously deciding anything, starts looking for a solution. So you add a pillow, just to be more comfortable, then another one. You tell yourself you sleep better propped up. You have been sleeping that way for years now, and it feels completely normal. But what your body is actually doing is keeping your head elevated to maintain partial gravitational drainage. It is compensating for a heart that can no longer fully compensate for itself. The medical term for this is orthopnea, and the way I screened for it changed when I realized most patients did not recognize the symptom. If I asked them directly, "Do you feel short of breath lying flat?" most would say no. They had adapted so gradually that the shortness of breath felt like their new normal. So I started asking a different question. How many pillows do you sleep with? If the answer is 3 or more, that becomes the first data point I pay close attention to. So right now, honestly ask yourself, could you lie completely flat and breathe comfortably? Not just fall asleep, but genuinely breathe easily with your head at the same level as your chest? Or does that feel wrong? Does it feel tight or difficult, or like you just cannot get comfortable unless your head is elevated? There is no judgment here. This is just information, but it is important information. Sign number 2, can you climb one flight of stairs without stopping? I want you to think about this carefully, because the answer is more revealing than most people realize. Not can you climb stairs at all, but can you climb one full flight without feeling unusually breathless, without your chest tightening, without needing to pause at the top? And more importantly, has this changed over the past year or two? Here is what the research shows. Many people with significant underlying heart disease can function adequately during low-demand activities, walking on flat ground, sitting, mild housework. The heart compensates by increasing output slightly, and the person feels relatively normal. But the cardiovascular system has limited reserves, and the demands of stair climbing exceed those reserves much faster than people expect. Climbing one flight of stairs increases the workload on the heart by close to 80% compared to walking on flat ground. 80%, and that is where symptoms appear that never show up during ordinary daily life. The chest tightness, the heaviness, the breathlessness that feels out of proportion to the effort. These are not signs of being out of shape. They are signs that the heart is being pushed to a limit it could manage more easily before. The key is change. A person who has always been mildly out of shape climbing stairs is not necessarily concerning, but a person who used to climb stairs easily and now finds one flight challenging, that change is the signal. Gradual is still a signal. The heart compensates so effectively in the early stages of disease that the deterioration feels like normal aging. It is not. Linda is 72 years old, a homemaker from Michigan who raised 3 children and spent decades keeping a household running. She is a composite of a pattern I have seen play out many times over. When she first noticed she was pausing at the top of the stairs, she assumed she needed to exercise more. When she noticed it happening after just 6 steps, she told herself she had been less active since her husband passed. She never connected it to her heart, not once. And why would she? She had no chest pain, no arm pain, no classic warnings, but that stair tolerance was one of the 3 things that ultimately led to her diagnosis. I will come back to her story throughout this video because each sign connects to the next in ways that matter. Sign number 3. Press your ankle right now. Go ahead, use your thumb. Find the soft tissue just above your ankle bone or on your shin about 2 inches above the ankle. Press firmly with your thumb for 15 to 20 seconds. Not a gentle touch, firm pressure. Then release and look at what happens. Does the skin spring back immediately? Good. Or does it hold the impression of your thumb for a few seconds before slowly filling back in? That indentation that remains after pressure is released is called pitting edema, and it is a sign that fluid has leaked out of your blood vessels and is accumulating in the tissue. Your blood vessels are designed to be selective about what they let through. They keep fluid inside where it belongs, but when the pressure inside those vessels rises, as it does when the heart is struggling to move blood forward efficiently, fluid gets pushed through the vessel walls and into the surrounding tissue. In the legs and ankles, gravity pulls that fluid downward, so it pools there. Your shoes feel tighter by late afternoon. Your socks leave marks around your ankles that take hours to fade. You might notice one ankle is puffier than the other, or that both legs feel heavy and dull by evening. Now, ankle swelling alone does not automatically point to heart disease. Kidney disease, thyroid problems, certain blood pressure medications, and simply sitting for long periods can all cause fluid accumulation in the legs. But here's what I want you to pay attention to: the combination. If you notice pitting edema in your ankles alongside difficulty breathing when lying flat, or alongside reduced tolerance for exertion like stairs, the likelihood that the heart is involved rises substantially. These signs do not exist in isolation. They are a pattern, and patterns tell stories that individual symptoms cannot. For Linda, the ankle swelling was the second piece. She had mentioned to her daughter that her feet had been swollen at the end of the day for several months. The daughter told her to drink more water. The internet told her to elevate her legs, and both of those things helped temporarily. But the swelling kept coming back, because the underlying cause was not dehydration. It was pressure, backed up pressure from a heart that was working too hard and falling behind. Sign number 4, and this one I want you to do right now while I explain it. Place 2 or 3 fingers on your wrist. Find the inner surface, just below the base of your thumb. Press gently until you feel a pulse. Got it? Good. Now hold that for 30 seconds. And pay attention not to the speed of your pulse, but to the pattern. Is it perfectly regular? Beat, 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 steady as a clock? Or does it feel erratic? Does it skip? Does the spacing between beats feel unpredictably uneven, like a drummer who keeps losing the tempo? Because if your pulse feels irregular, if it jumps and stutters rather than maintaining a steady rhythm, you may be experiencing atrial fibrillation, and this is not a minor detail. Here is why this matters so much. The heart has 4 chambers. The 2 upper chambers, called the atria, are supposed to contract in a smooth, coordinated way before the lower chambers respond. It is a carefully sequenced electrical event that happens more than 100,000 times every single day without you ever thinking about it. But in atrial fibrillation, the atria stop contracting properly. The electrical signals go haywire. The atria quiver, flutter, fire chaotically instead of squeezing with purpose. And here is the dangerous consequence. When the atria quiver instead of contracting, blood does not get pushed cleanly into the lower chambers and out to the body. It pools. It sloshes around in the upper chambers and stagnant blood clots. Those clots can then be pumped out into circulation. If a clot reaches one of the arteries supplying the brain, it causes a stroke. Ischemic stroke, the kind caused by a blocked artery, accounts for roughly 87% of all strokes. And atrial fibrillation is one of the leading causes. People with undiagnosed atrial fibrillation have a risk of stroke that is close to 5 times higher than those without it. 5 times. Let that number sit with you for a moment. The reason so many people with atrial fibrillation do not know they have it is that it can come and go. It does not always cause obvious symptoms. Some people feel heart palpitations or describe a fluttering in their chest, but many people feel nothing at all during an episode. Their pulse is irregular, their risk is elevated, and they have no idea. Many modern smartwatches have built-in ECG sensors that can detect irregular rhythms and alert you to them, but not everyone has one, and your own fingers are available right now. If your pulse feels irregular today, or if you check it multiple times over the coming week and notice irregularity even once, that is worth reporting to your doctor. Do not wait for symptoms. Do not wait for it to happen again. Mention it. Now I want to pause here because if you are finding this information useful, I need to ask you one thing. Tap the like button, not as a favor to me, but because the way this platform works, that signal tells the algorithm that this information is valuable, and the algorithm shows it to more people. More seniors over 60 who are walking around right now with undetected signs, who have never heard of pitting edema or orthopnea or atrial fibrillation, and who deserve to know what you now know. One tap, that is all it takes. Sign number 5. Now look in a mirror if you have one nearby, or just remember to do this later today. Look at your neck, specifically the right side, just below the jaw, along the long muscle that runs from behind your ear down toward your collarbone. Do you see visible pulsations? A rhythmic, visible throbbing in the veins? Not your carotid artery, which pulses with every heartbeat. I am talking about the jugular vein on the right side of the neck, which should normally be quiet and flat when you are sitting upright. Now look at your fingernails under good light. Can you see a faint, rhythmic pulse at the base of the nail? A subtle throbbing just under the skin, visible as a slight change in color or a small movement with each heartbeat. These findings, when present, are called peripheral signs of aortic regurgitation. And aortic regurgitation is a condition most people have never heard of, despite the fact that it affects a meaningful percentage of adults over 60. Here is what is happening. The aortic valve sits between the left ventricle, the heart's main pumping chamber, and the aorta, the large artery that delivers blood to the rest of the body. This valve is supposed to open when the heart contracts, let blood through, then snap shut to prevent backflow. But when the valve becomes leaky, when the leaflets no longer close completely, blood flows backward with every heartbeat, back into the left ventricle. The ventricle has to work harder with every cycle, pumping not just the normal volume, but also the blood that leaked back. Over years, this causes the ventricle to enlarge and eventually weaken. The peripheral signs appear because of the dramatic pressure swings this creates inside the vascular system. During each heartbeat, pressure surges. Between beats, it drops abruptly. That pulse pressure, as doctors call it, becomes so pronounced that it becomes visible at the periphery, in the neck, in the fingernails. Some people even develop a subtle head nodding with each heartbeat, known as the de Musset sign, or visible pulsations of the small vessels at the back of the throat. These findings are not common. I want to be honest about that. But when they are present, they are important, and they are the kind of thing that would never come up in a 7-minute appointment unless the patient or the doctor was specifically looking for them. Most are not. So I'm showing you how to look for yourself. Sign number 6. Here's a test you can do in 10 seconds. Hold both of your index fingers together back to back so that the fingernails are facing each other. Then place your thumbnails together as well. Look at the space between the nails. There should be a small, roughly diamond-shaped gap visible between the nail beds. A small window of light. Ophthalmologists and cardiologists call this the Shamroth window test, named after a South African cardiologist who used it to screen himself when he was hospitalized in the 1960s. Now, is that gap there? Can you see that diamond of light? Or are the fingernails pressed flat against each other with no space between them at all? If the gap is absent, if the nails meet flush with no window, that is called finger clubbing. And it is one of the more subtle but telling physical signs in all of medicine. Here is what causes it. Clubbing develops when the fingertips receive chronically low oxygen levels over an extended period. The tissue at the end of the fingers, the soft pad beneath the nail, gradually thickens. The nail plate begins to curve downward. The angle between the nail and the nail bed, which is normally around 160 degrees, flattens and eventually becomes convex. The fingertips take on a rounded, bulbous appearance, sometimes described as resembling drumsticks or the end of a chef's knife handle. Heart disease causes clubbing. So do many serious lung conditions, including chronic lung infections, pulmonary fibrosis, and in some cases, lung cancer. Certain gastrointestinal diseases can cause it as well. The common thread is prolonged inadequate oxygenation of the tissues, and because clubbing develops over months and years, most people simply do not notice it happening to themselves. They look at their own hands every day. The change is too gradual. This is why I recommend looking at old photographs of your hands. A photo from 5 or 10 years ago. Look at the shape of your fingertips. Have they changed? Have they become more rounded at the ends? Do the nails curve differently than they used to? If the answer is yes, that is worth bringing to your doctor's attention. Not with alarm, but with specificity. Show them the photo. Show them the current fingertip. That kind of concrete visual comparison is exactly the kind of thing that leads to early detection. I also want to say something important about this sign in particular. The absence of clubbing does not mean your heart is fine. Most people with cardiovascular disease do not have clubbing. It is an advanced sign. But when it is present, it tells you that the body has been oxygen deprived for a significant period, and that underlying cause deserves urgent evaluation. Sign number 7, and for this one, you need to find a mirror with good light. Look at your eyelids. Specifically, look at the skin near the inner corners of your eyes, both upper and lower lids. Do you see any yellowish or cream-colored patches? Small, slightly raised deposits that look waxy or almost fatty. Not red, not a rash. Yellow, waxy, slightly elevated above the surrounding skin. Those deposits are called xanthelasma. Xanthelasma palpebrarum, to use the full name. And they are made of cholesterol, specifically cholesterol-laden white blood cells called foam cells, which have accumulated just beneath the skin surface. Now I want to be precise about this because xanthelasma alone does not mean you have heart disease. You can have xanthelasma with completely normal cholesterol levels, and you can have dangerously abnormal cholesterol with no xanthelasma at all. But here is what the research consistently shows. In a 2015 meta-analysis published in the BMJ that reviewed data from over 13,000 individuals, the presence of xanthelasma was associated with a significantly elevated risk of heart attack, ischemic heart disease, and death from cardiovascular causes, even after controlling for cholesterol levels. Let me say that differently, because it is important. Even in people whose lab tests showed normal cholesterol, xanthelasma still predicted higher cardiovascular risk. That tells us the deposit is not just reflecting cholesterol numbers on paper, it is reflecting something about how the body is processing and depositing lipids at the tissue level, something that standard blood tests may not fully capture. Think of the arterial wall like the inner surface of an old pipe, a pipe that was once smooth and unobstructed. Over decades, minerals and deposits begin to cling to the inner wall. The opening narrows, flow is restricted, pressure upstream rises. This is atherosclerosis. And xanthelasma may be the visible tip of an iceberg, the only externally visible evidence of a process that is happening silently inside your arteries at the same time. If you see these patches, do not panic, but do get your cardiovascular risk fully evaluated, not just a cholesterol panel. A full assessment that includes inflammation markers, blood pressure trends, and if your doctor agrees, potentially imaging. Now I want to come back to Linda, because when she finally came in, it was not because she was worried about her heart. She came in because her daughter had pushed her to. She was sleeping on 4 pillows. She was pausing halfway up the stairs. Her ankles were visibly swollen by mid-afternoon. She had been explaining each of these things away for the better part of 2 years. The pillows were more comfortable. The stairs were hard because she needed to walk more. The ankles were from standing too long in the kitchen. None of those explanations were unreasonable. None of them were obviously wrong. And that is exactly what makes early heart disease so insidious. Every sign has a plausible, mundane explanation. And so people wait, they adapt, they accommodate, until the compensation fails and the crisis arrives without warning. When Linda's echocardiogram came back, it showed reduced ejection fraction. The left ventricle, the main pumping chamber, was not contracting with its usual force. Blood was moving through, but not efficiently. This is a condition called heart failure with reduced ejection fraction. And the early stage version of it, the version Linda had, is one of the most treatable conditions in all of cardiovascular medicine when caught early. The treatment options are extensive. The potential for stabilization and meaningful improvement is real. A 2022 review in the Journal of the American College of Cardiology confirmed that patients diagnosed and treated in early stages have significantly better long-term outcomes than those who present later. The team caught Linda's condition before any irreversible damage had been done. She started treatment. She made specific changes to her diet, her fluid intake, her activity level. 4 months later, she told me, "I am climbing those stairs again, not fast, but I am doing it." That is what early detection looks like, not dramatic, just options, just getting your life back one flight of stairs at a time. Now, I want to talk about something that most videos like this leave out, and it is the part I consider the most important. Knowing these 7 signs is not enough if you do not know what to do with them, and that is not obvious. Most people, when they recognize a concerning sign, do one of 2 things. They either panic and go straight to the emergency room over something that could wait for an appointment, or they dismiss it and do nothing because they do not want to seem like they are overreacting. Both responses are understandable. Neither is particularly helpful. Here is what I actually recommend. First, make a written list. Right now, while this information is fresh, go through the 7 signs: the pillow count, the stair test, the ankle press, the pulse rhythm, the neck and nail pulsations, the fingernail gap, the eyelid deposits. Write down which ones you notice something with. Be specific, not just swollen ankles, but swollen ankles for 3 months, worse by evening, both legs, pitting edema present. Specificity is what transforms a vague concern into actionable clinical information. Second, bring that list to your next scheduled appointment. You do not need to create an emergency visit for any of these signs in isolation, unless you are also experiencing chest pain, severe difficulty breathing, sudden arm numbness, or facial drooping. Those are emergency symptoms. These 7 signs are monitoring signs. They are the pre-warning system. Bring the list, walk your doctor through it, and ask specifically what follow-up they recommend. Third, if your doctor dismisses your concerns without examination, push back. You are allowed to say, "I would like this documented in my chart." You are allowed to ask, "What would need to be true for us to pursue further testing?" You are not being difficult. You are being an advocate for your own health, and that is not just your right, it is your responsibility. Now let me give you something concrete, because I know that identifying signs without a next step is frustrating. For the pillow sign and the ankle swelling, if both are present, the most important initial test is an echocardiogram. This is an ultrasound of the heart. It measures how effectively the heart is pumping, looks at valve function, and can detect the kind of structural changes that accompany early heart failure. It is non-invasive. It does not involve radiation, and it can be arranged by your primary care physician. You do not need to see a cardiologist to get an echocardiogram ordered. Ask for it by name if you have both of those signs. For the pulse irregularity, the most useful first test is a 12-lead electrocardiogram, an ECG. This can be done in any doctor's office in a matter of minutes. It captures the electrical activity of the heart and can identify atrial fibrillation if it is occurring at the time of the test. However, if your atrial fibrillation is intermittent, a standard ECG may be normal during the appointment, even if the arrhythmia is occurring regularly at other times. In that case, ask your doctor about a Holter monitor, which is a portable ECG device you wear for 24 to 48 hours to catch intermittent rhythm disturbances. For the fingernail changes, xanthelasma, and any visible pulsations in the neck or nails, the most useful step is a comprehensive cardiovascular risk assessment. This goes beyond a standard cholesterol panel. Ask your doctor about measuring your LDL particle number, your Lp(a) level, which is a genetically elevated lipoprotein that dramatically increases cardiovascular risk and is often not included in a standard panel, and your high-sensitivity C-reactive protein, which is a marker of systemic inflammation that is now recognized as an independent cardiovascular risk factor. These are not exotic tests. They are available at standard labs, but many physicians do not order them routinely unless a patient asks. So ask. Now I want to address something directly, because I know some of you are thinking it. Some of you are thinking, I already went to the doctor last year and they said everything was fine, and I am telling you that is not the same thing as your heart being healthy. A standard annual physical, even a thorough one, rarely includes an echocardiogram or a Holter monitor or a full lipid particle analysis. What it includes is a blood pressure reading, a basic cholesterol panel, and a few minutes of conversation. That is not nothing, but it is not a cardiovascular evaluation. Those are different things, and knowing the difference could matter enormously. Some of you are thinking, these signs could all have simple explanations, and you are right, they could. I am not suggesting you have heart disease. I am suggesting that if you are over 60 and you recognize 2 or more of these signs in yourself, you deserve a more thorough evaluation than you may have received. That is the only point. Not alarm, not certainty, just informed action. Here is what I want you to take away from today. Your body has been communicating with you, maybe for years. The number of pillows you need to breathe comfortably at night, the way stairs feel different than they used to, the slight puffiness you stopped mentioning because you stopped thinking about it, the irregular heartbeat you felt once and then forgot. None of these are random. None of these are just aging. They are data, and data can be acted on. The difference between the people who catch heart disease early and the people who do not is not luck. It is not better genetics. It is usually one thing. Someone told them what to look for, and they looked. That is all I have tried to do today. I have tried to tell you what to look for. Now you look. Write your observations down. Bring them to your doctor. Push for the tests that match what you found. And if someone in your life, your mother, your father, your spouse, your neighbor, who always seems tired and blames it on age, if someone comes to mind as you have been watching this, send them this video, not the link. Text them directly and say, I just watched something I think you need to see. That personal message is the one that gets watched. Now type the words I finished in the comments. That small action tells me you stayed, and it helps this information reach someone else who is sitting somewhere right now with 3 pillows under their head, wondering why they cannot breathe. They need to know why. And you have the ability to help them find out. Your health is your greatest wealth. Protect it, and I will see you in the next one.